Hey, Paul.
Yes, Matt.
I wanted to make sure I had your attention. I wish I knew sign language.
Oh, God. All right.
Yeah, I just think it would be handy.
Matt, I was, so we're doing an asthma episode, just a peek behind the curtain. And I found a pun that mentioned Vlad the Inhaler, but I didn't actually like it. It didn't make a lot of sense. And I was trying to reverse engineer it. I just want you to know that the shame that I felt when I realized what I was doing and just how I was spending my time was just like an ice pick to my heart, just for whatever that's worth.
Okay, so no pun.
Vlad the Inhaler is my pun. And just do with that what you will.
Okay.
You can make the joke yourself.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cashlight Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Franquato, here with my great friend and America's primary care physician, maybe even the primary care physician, Dr. Paul Nelson Williams.
Hi, Matt. Paul? And as always, I'll say I'm a primary care physician at least. Good to see you. How are you?
And just a reminder to post the hashtag MAPA for Make America Paul again.
This is going to be posting well after the fact that is relevant, question mark. We'll see how things go.
No, I just want that to be an ongoing thing. Anyway,
Great.
On tonight's episode, a much-needed update to asthma with a fantastic guest expert and longtime Curbsider, now runs his own podcast, but Dr. Cyrus Askin. We'll tell you more about him in a second. But Paul, can you remind people, what is it that we do on the Curbsiders, and can you introduce our co-host for tonight?
Sure, Matt. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. As you mentioned, we are joined by Dr. Paul Wirtz, one of our newest wonderkins, one of the up-and-comers, hopefully one of my future replacements, who did yeoman's work both writing the episode and then also co-hosting with us. So, Paul, how are you?
I'm doing well. I don't know about all that, but I'm happy to be here.
And I should mention to the audience, we're recording with two Pauls. So I'm going to call Paul Wirtz. I'm going to call you Wirtz, and Paul Williams, you've been here first, so we're just going to call you Paul. So Wirtz, fair. Can you please tell the audience about our wonderful guest?
Of course. So we have a fantastic conversation with our guest, Dr. Cyrus Askin, who is a longtime beloved member of the Curbsiders family and a current pulmonary and critical care doctor. Cyrus is now serving as an internal medicine associate program director at an academic medical program in El Paso, Texas. He is the medical director of their intensive care unit and an assistant professor of medicine for the Uniformed Services University. He is also the co-founder for Critical Care Time, an intensive care podcast where he and his co-host dive into the high-stakes world of critical care medicine and discuss all things critical care. In this episode, he teaches us all about asthma and SMART or MART therapy. So without further ado, let's get to it.
And a reminder that this and most episodes will be available for CME for all health professionals through VCU Health at curbsiders.vcuhealth.org. And if you haven't done so yet, sign up for our Patreon at patreon.com/curbsiders, where you get twice monthly bonus episodes, ad-free episodes, and a whole bunch more. Patreon.com/curbsiders. Okay, Cyrus, so the listeners have heard your bio, but they want to know, what hobby or interests are you currently up to outside of medicine?
Yeah, no, it's a great question. And thank you guys so much for having me on as a guest. This is really exciting. It's sort of like this weird, like full circle experience that I've had with you guys. So I'm tremendously grateful.
Yeah, it's it's got to be at least 7 years, Cyrus, that you've been working with Curbsiders. Maybe longer.
Maybe 8 or 9. I lost track, when time flies when you're having fun. So
yeah.
So hobby outside of medicine. So, I've got one child, one on the way. So that kind of keeps me pretty busy when I'm not at work. And Matt, I know you're familiar with that life. Aside from that, so I spend a good amount of time in the gym whenever I can. I've sort of like in this constant balance between lifting and cardio and like trying to figure out what works for me without causing all of my joints to spontaneously explode. Such is life, right? For those of you that might be watching, I have this whiskey collection here, so I do enjoy a sip or two every now and again. The guitar I still play from time to time when I have the opportunity. And then really my podcast, Critical Care Time, which I really credit you guys to helping me, like inspiring me to get that off the ground. That takes up a lot of my time too. So between the kids, the gym, and all that good stuff, yeah, I stay pretty busy.
My joke is that like when people ask me if I play golf, I'm like, you're not allowed to play golf and have a podcast. So Cyrus, do you play golf?
I do not. Absolutely not. No way.
Yeah.
Yeah. I would be sleeping. I'd be sleeping on the couch if that were the case.
Smart man.
Let me channel Mark Maron, Cyrus. I may have even asked this before, but who's your guitar guy? Like, do you have a particular guitarist that you like a lot or that you're actually inspired by? I mean, I'm sure you have a list, but so I'm going to narrow it down to a couple if you're able to.
I will always
or gal,
love.
By the way, not to be sexist.
No. Yes. I will always love Carlos Santana. And he's the one that kind of got me into Paul Reed Smith guitars because I just think they're so beautiful. The tone is amazing. That's like something I'd love to buy one again when my wife loosens the purse strings a little bit for me. So there's that.
Sound like a baby, Cyrus. That's a good way to start.
We're done. After 2, we're done. Like that's I can't. The transition from like man to man to zone defense is very scary to me. I'm not very fast, so that bothers me a lot. The other guitarist who I really like, and I know this is maybe a bit of a polarizing answer, is John Mayer. I think he's a great acoustic guitarist, and I think his ability to improvise. I've heard him live a few times. It's really amazing. I mean, I've listened to all the old band. Like I love Guns N' Roses and Slash. Like I love listening to Led Zeppelin. More contemporary. So the Mars Volta is actually probably my favorite band. And I think Cedric Bixler-Zavala is like one of the most like amazing singers. And Omar Rodriguez-Lopez is like a phenomenal guitarist. So yeah, my interests are like all over the place when it comes to music. But
yeah, I don't think anyone's arguing that John Mayer is not a good guitarist. I think
maybe
from a personality standpoint,
yeah.
You may not want to spend time with him, but the guy can play guitar.
There you go. Yeah. So
all right, we're gonna get Paul going on music here, and we're never gonna get to the cases. So I think we should get to a case because I think we're gonna run long otherwise. So Paul Wirtz, will you read our first case from Kashlak Memorial Hospital?
Yes, I'd be happy to. So we've got Allie Buterol. She's a 32-year-old woman who presents to your office for intermittent worsening cough and shortness of breath over the past year. She's establishing care as she recently moved here from across the country and began noticing symptoms shortly thereafter. She is also currently pregnant at 22 weeks gestation. She notes a remote history of mild childhood asthma, but nothing beyond elementary school age. Her mother has eczema, her sister has eczema, and bad allergies. She states that the symptoms used to occur 2 to 3 times per month, but now occur 2 to 3 times per week, especially at night. She also has accompanying allergy symptoms that started recently. She manages these with some over-the-counter cetirizine. She has tried a coworker's albuterol inhaler, which helped her symptoms, and is requesting one for herself. So in general, when you're talking to a new patient with potential asthma symptoms, I guess I'm interested in how do you conduct this interview and how do you elicit the specific triggers and things that help you talk with patients about their potential asthma.
So Paul, yeah, great. That's a great question. A great way to, I think, start the discussion. Yeah, I'd probably just give her the albuterol and send her on her way. And that's the show.
That's my bit. Come on.
Yeah. So no, there's obviously there's a lot to unpack here. It's like I said, it is a great case. So initially, I think it's really important to start, I think, with an open-ended question. So a lot of times what I use in my clinic is, hey, welcome to the pulmonary clinic. It's great to meet you. I'm Dr. Askin. What the heck are you doing in pulmonary today? How can I help you? What's going on? And oftentimes that is a great sort of informal way of establishing rapport and getting your patient to share a lot of the information that you would otherwise be asking kind of piece by piece. Now, depending on the situation, sometimes you don't get all of the information that you need. And so I'll start to ask certain elements of the history, get at certain elements. Now in this case, you've given a pretty classic story for someone that we call, has allergic type asthma, classic asthma, high T2 or high T helper 2 type asthma, given the eczema, the family history, the association with allergies, et cetera, et cetera. And so with that all being said, I'd probably get at things like, is there an environmental association? Hot versus cold, humid versus dry? Do you have worse symptoms when there are changes in climate? when the pollen count is high? Do you ever I know in my smartwatch, you can look at the AQI, and I follow that from time to time because I'm a nerdy pulmonologist. And so if you see an association between the air quality index and worsening symptoms, that could be a little bit of a suggestion that there could be something going on in areas where there's a lot of dust, wildfires. So, here in Texas, there could be dust storms. Obviously, California has their issues with wildfires. So that could be something you want to know about. Kind of moving on from that, other kind of big things to be would be like activity association. So when you exercise, is that when you have symptoms? Is it only when you exercise? Is it worse when you exercise? If you exercise indoors versus outdoors, is there a difference? I'll often ask that. I'll ask, you gave us that family history, which is awesome, but I'll often ask, history of asthma, history of other lung diseases. And then a couple big things that I'll kind of close out with would be history of prematurity or history of quote unquote childhood asthma. So when it comes to prematurity, really what we're asking about is born prior to or at about 34 weeks. And the reason being is that we know that distal airway development, terminal airway development, surfactant production, all of those things don't really come to a head until later in the pregnancy. And in certain cases, in extreme cases, you can see bronchopulmonary dysplasia. You can also see folks that have, they think back to their childhood and they're like, yeah, I was always in and out of the hospital. Well, that can be related to, some degree of immunodeficiency or immune dysfunction that a patient may have grown out of, or maybe not, hard to say, or maybe not hard to say, but it kind of depends on the case. So all of that, I think, goes into why I asked that particular question. And then finally, I asked that question about childhood asthma. So a lot of times, and especially you can see it in these folks that have a history of prematurity, not always, but sometimes there's that association. They'll have this quote unquote diagnosis of childhood asthma, which may or may not be rooted in spirometry. I think we'll get to that later. But they'll basically have symptoms consistent with asthma that abate as the patient gets older. Why? Because you see increased airway diameter, improvement in airway inflammation or damage that may be reversed as the patient kind of continues to mature. Especially if they're on ICS. So if you start them on ICS or inhaled corticosteroid early, that may actually mitigate some of those inflammatory changes. We don't totally understand this idea of childhood asthma and why it disappears and why it can relapse, but that's definitely something I ask about as well.
Yeah, and we're going to get to the Th2 high and low asthma at some point, but let's just, this person seems to have asthma, like pretty good story for it. Childhood asthma, family history of allergies. It sounds like maybe moving environments like kind of re-triggered it. Mm-hmm. But when we talked to Dr. Blagev, and this was like 400 episodes ago, Cyrus, I think you were part of probably the planning or the recording of that episode.
Yes, but indeed.
She mentioned that she feels like you could probably get away with not doing spirometry because it's not always available. So where are we at with that these days in like making the diagnosis of asthma? Is spirometry 100% necessary? And I was surprised to see peak expiratory flow testing even mentioned in the GINA guideline.
Well, I would say that the guidelines and kind of best practices would definitely support using spirometry. If not spirometry, you would use that peak expiratory flow. And we can sort of touch on that here in a moment. What I would say is that I think in certain situations, depending on patient factors, institutional factors, etc., there may be a place for empiric therapy with corticosteroids, inhaled corticosteroids, as sort of a diagnostic and therapeutic approach. Now, that is not the standard of care, and I want to be very clear on that. But, I've done it before, and maybe that's me evoking I'm a pulmonologist, I hear what this patient is saying. The patient doesn't have any employment related issues here. So for example, if you're in the armed forces, if you are in let's say certain public services, fire, EMS, police, there may be a requirement for you to have a solid diagnosis, a bona fide diagnosis with objective data. For a lot of my patients, that is not necessarily the case. And so it's like, well, risks versus benefits. We try to do spirometry a couple times and you cough too much or you weren't able to actually complete the test per ATS standards. Let's just go ahead and see how you do with some inhaled fluticasone and go from there. Those are rare cases, I will say. Otherwise, we're really using spirometry, and then in some occasional circumstances, we'll use peak expiratory.
Yeah, Paul, what are you seeing in your practice?
Yeah, I was going to go back to actually our case stem. So for this patient, it's funny because in our script, we're like, well, this is obviously asthma. And I'm like, I could see a world where I think this is allergic rhinitis and the patient's short of breath because she's 22 weeks pregnant and has restrictive lung disease from a gravid abdomen. And so so maybe obviously asthma, maybe not, but I think sometimes it's not totally clear. And but to your question, Matt, I don't see the PFTs ordered consistently. In part because I feel like we've had them all come back normal, which is not surprising much of the time, and that doesn't tell us that the patient does not have asthma. So it gets a little bit sort of sticky from that standpoint. So I guess that would be the question I would have for Cyrus. Probably I would imagine you would do pulmonary function testing after this patient delivers, just so the water is not too muddy. But then also, what do we do with normal results then?
Okay, perfect. So first and foremost, you mentioned that this patient is pregnant. That rule of thirds that we learned eons ago is still relevant. So that kind of idea of a third of folks with asthma get worse, a third get better, a third stay the same. That is still kind of what I teach my residents. That's still kind of our general understanding. So that may be why these symptoms are coming to a head. Or it could be the fact that this patient has dilutional anemia and a gravid uterus and et cetera, et cetera. Recognize that this idea of just dyspnea, the differential for dyspnea is massively huge. And involves like all of the organ systems from the integument all the way to the heart, right? So with that being said, if we assume this patient might have asthma, then you could go ahead and get spirometry. There's not a reason why you couldn't get spirometry in a patient that is 22 weeks pregnant. But as you said, the results may be skewed by the fact that they may have restrictive pattern on their PFTs, depending on how gravid they are, et cetera, et cetera. But I would say in general, if we take a step back and say, okay, take pregnancy out of the equation, how do we approach this patient from a pulmonary function testing standpoint? Well, as you alluded to, Paul, normal pulmonary function tests in a patient who's not terribly symptomatic on that day when they come to see you, it tells me nothing. You may see if you order spirometry with bronchodilator, and the idea there is like, I don't care whether or not they have obstruction. I want you to do a bronchodilator challenge and see if they have that change. That could be helpful. If that's not helpful, you may see, and this is like very sensitive, but totally not specific and not guideline driven. But in my practice, if I look at that peak FEF, so the forced expiratory flow, 75 to 25, that'll kind of show you medium airway, evidence of medium airway disease potentially. So basically what you're looking at is how well does air escape from those medium-sized airways? And if there's a limitation and a big bronchodilator change in those medium-sized to small-sized airways, that may be indicative of asthma, potentially. All of that is to say, go ahead, Matt. Did you have a question?
No, I've seen people point to that on PFTs and say, even more general than asthma, just say this patient could have small airways disease, which I guess is like, I had to look up what that is could be asthma or COPD, some issue with the small, like less than 2 millimeter airways or something.
Right. Yeah. So that could be seen in like a bronchiolitis, or it could be seen in bronchiectasis that's affecting the really smaller airways. Because we recognize, bronchiectasis is also a obstructive lung disease. A lot of people forget that. They're like, okay, so it's COPD and asthma, but bronchiectasis can be too. And then there's of course overlap. But that's just that's something that I do, something that I was taught when I was in training. You can look at that, but really, I wouldn't say, oh well, their FEF 2575 is reduced, so they have asthma, and they have a bronchodilator response, so they definitely have asthma. No, I would look at other tests. So if they have a normal spiro with BD, or spirometry with bronchodilator, then I'm going to be looking at my provocative tests or evocative tests. And so your direct bronchoprovocation test, typically that's done, is a methacholine challenge test. And in fact, in my practice, I've kind of jumped to doing those very early. In fact, I'll often do those right away because based on availability of spirometry, it can take a while to get spiro, see the patient or talk to them again, then order the meth, and then we have to fit them in the schedule. When I order a methacholine, I get baseline spirometry, and then I get a graded test with increasing doses of methacholine. And then I kind of get a pretty good answer. I mean, your methacholine is a tremendously sensitive test. It's not very specific, but it's tremendously sensitive. I want to say upwards of 95%, maybe 98% if memory serves. Don't quote me on that, but it's quite high. Or I may get an exercise and challenge test, if that's kind of consistent with the patient's symptoms. I might get them both. And then there are plenty of other tests we can sort of talk about. But basically, to sort of answer the question, yes, every once in a while, I'll make a quote unquote clinical diagnosis. I really hate doing that. I really try to avoid doing that. There are so many other things that can look like asthma. So I think it's really, really important to do that spirometric testing. And if you are in a resource limited environment and all you have is access to expiratory flows, sure, you can do that. But the trick is you've got to get multiple readings in the morning and in the evening over like a 2-week period and compare that to what will be predicted based upon the patient's demographics. And MD-Calc has like a little calculator you can use to come up with that.
So to recap a little bit, basically when someone with asthma, let's just say asthma, and they have no symptoms on that day, they might have a normal spirometry. But if we did a bronchodilator response, maybe we would see something that might capture a couple more patients or help us make the diagnosis.
Correct.
And then you said you could look at this FEF 25-75, and is that reduced? Is there a bronchodilator response there? That could be a clue, but maybe not what we hinge our whole diagnosis on.
Agreed.
And then
Yep.
you said that what you like to do just for practical purposes to save a patient a trip and is do baseline spirometry. So spirometry probably with the bronchodilator. Then they do the methacholine challenge where they step up how much they're getting and you see if you can induce symptoms.
Well, so typically what happens is they'll come in, they'll just blow a baseline.
Yeah.
And that'll be kind of their spirometry. You can't, unfortunately, give them bronchodilator at that time because it's going to ruin your methacholine.
Okay.
So you basically roll right into the methacholine. And the way that the respiratory therapists will do that is they follow the ATS protocol, giving increasing doses of methacholine. And then they're going to be looking for a drop, like either the appearance of obstruction or a drop in FEV1. Mm-hmm. There's kind of like some variation in terms of what kind of a drop you're looking for based upon like the institution, for example, like, if you're again in, well, I'll just leave it at that. But basically, you're going to look for a drop in FEV1, and then you're going to give that person bronchodilator and see if they should have a reversibility. They should reverse at that point. And that's how I use the methacholine.
Okay.
Yeah.
Great. And then with the peak flow, which is kind of our peak expiratory flow as our last resort, you'd get them a bunch of readings morning and night because, when I've done them at bedside, you get a variation from reading to reading, and then you would sort of compare them to what you would expect for someone that age and that size, and then we can kind of look at the charts to see if they would meet criteria or not. Okay.
That's essentially right. Yeah, you're going to be looking for basically 2 weeks worth of data, and you want to see greater than 10% variability,
Mm-hmm.
Assuming technique is right. But like, you're not going to, I don't know about you, but I'm not going to be there in the morning and the evening for 2 weeks.
Paul moves in with all his patients for 2 weeks.
Really dedicated Dr. Cyrus. Yeah.
I know, I'm a slacker. Yeah. So that's why it's like really not ideal. But I think the takeaway for this is, although GINA and pulmonologists agree that the gold standard and what should be pursued is objective diagnosis. If you're relying on a peak expiratory flow, then the threshold for starting empiric inhaled corticosteroids is pretty low. Mm-hmm. So I think that then feeds into the idea of, okay, if the patient's really symptomatic and you think it's asthma, probably as long as they're doing good techniques, swishing and spitting after use, etc., they're probably not going to take a big hit from a trial of something like a fluticasone or a budesonide. But again, gold standard is testing, and that testing should be spirometry.
Okay, so let's say we've done spirometry. We're in a good situation. We've done spirometry. We've observed a bronchodilator response. We didn't have to do the methacholine challenge. Mm-hmm. And she has symptoms that we think are compatible. So we're thinking this is asthma. So I guess, Paul Williams, I'm going to ask you because I don't want to jump the gun. Are we ready to talk about treatment, or do we have more diagnostic questions?
Thank you for asking. Yeah, actually, I was hoping I get a chance to jump in here and ask Cyrus. Okay. Would you mind talking to us a little bit about staging? Like, so we've made the diagnosis, but I know the treatment is dependent on the stage. At least, sort of back when Matt and I were residents, there was this mild intermittent concept, which may or may not germane. Then you throw an albuterol at them, and then you'd escalate therapy if you were actually paying attention and asking about symptoms. But can you talk us what the current guidelines tell us about staging, what we're to do with that information before we start treatment?
Yeah. So I think I also learned this idea of like mild, intermittent, persistent, etc. And I'll be honest with you guys, and maybe this is just because I'm lazy and a bad doctor, but I don't really use those terms a lot. I kind of just try to get a feel for, like, I really focus on more patient-centered language and patient-centered, like the patient experience, I guess, which maybe sounds kind of fluffy, but I think it's really important. So if the patient's like always symptomatic and waking up at night with symptoms, and you can sort of elicit this through the asthma control test. Like you can use an asthma control test, which we may talk about a little later, but basically it's a questionnaire that you can use, even in someone who you think could have asthma, but you don't know. And so if their score is really low, and you're thinking, okay, they might have asthma, or you make the, let's say in this case, like you have the spirometry, you're like, yeah, they have asthma, and their score is really low. That's probably more of what I would use to say, okay, maybe I need to start this patient at step 2 or step 3 versus step 1. And we could talk about what that means in a moment. But so I don't really like hem and haw or agonize over like calling it moderate, intermittent, or whatever that, I don't even think that's a thing, but moderate, persistent, or whatever. I just kind of look at like, yeah, I was like, that's not a thing. I was like, I just kind of focus on
persistent, intermittent.
Yeah, they're persistently intermittent and moderately severe. But I really just focus on trying to understand how bad are their symptoms, how much is it affecting that patient on a day-to-day basis? Is this episodic to the extent where there's like the potential for trigger mitigation, trigger avoidance? Is this not? And so I kind of have to go with a treatment that's going to be targeted around the trigger. Or is this like, yeah, the person's got symptoms pretty often and it's kind of life-limiting and impactful? We're going to be a little more aggressive. And that's kind of to an extent where practice patterns are going to vary. But in general, that's how I kind of like 3 buckets would be like, does the patient have symptoms only in certain circumstances? Does the patient always have symptoms, but they're fairly mild in nature based on ACT score or my kind of general gestalt? Or is this person pretty much always short of breath and they're not able to play with their kids, really take care of business at home, they're having issues at work, etc.? That's how I sort of approach it. And I just find that to be a little bit more practical.
I like it. I can remember that. And I guess, should we talk about the ACT score? Like, do we have enough information to score hers, or do you need like spirometry data for that? I have not used that score before.
No, so that the ACT, so the asthma control test is super effective. I would encourage everyone to use it. The nice thing is there are like a million different printouts that you could just hand your patient or have your nurse or MSA or whomever give the patient that while they're waiting to see you. And then you'll get it back. So just in a nutshell, it's basically you get scores from 5 to 25, where a score of 19 to 25 would indicate well-controlled asthma. Anything less than 19 would be not well-controlled or perhaps even poorly controlled asthma. And the 5 questions that are rated on a 5-point scale include frequency of shortness of breath over the last month, limitations on daily activities, frequency of asthma symptoms at night, how often are you using a rescue inhaler, and then finally, what is your sort of assessment of your own asthma control? So you'll take 1 out of 5 for all of those, sum it up, and you'll get an answer. As you can imagine, that's also great to report longitudinally. So like when I see a patient in clinic, if I have an index ACT score, I can then kind of track them over time and use that to guide, do I step up? Do I step down? Am I totally off the mark? So that's how I use it.
Beautiful. Okay. So, for somebody that, let's say they have an ACT score of, I guess let's start with greater than 19. So it's 20 to 25 range. Let's give her, it's on the more mild end. I guess that means maybe she's doing better at this time. What might you start at as your first step in therapy?
Yeah. So I think the first question is, okay, is this an ACT score that is, how accurate is this? Like sometimes what I found is sometimes patients will underreport symptoms too. So if someone's in my clinic for asthma or for shortness of breath, but their ACT score is like 24, then I'm like, well, hold on. Like there's some discordance here. And so then I have to kind of tease through that a little bit more. But let's say, this is a good day and you push them a little bit more and you're like, okay, yeah, you've got a good ACT score, but you are reasonably symptomatic. And I think we should start treatment. The data for inhaled corticosteroids preventing progression is not the most robust data in the galaxy. So we know that it helps reduce inflammation. We know that it does have an impact, but how do you quantify that impact? What is that impact? It's much, I guess, less significant to the patient on a day-to-day basis than how is it going to improve my symptoms? And that's where you get a lot of bang for your buck is symptom control. So with that being said, a patient like this who's like, yeah, my neck's pretty good, but really, I do notice when I'm exercising, that's really when I have symptoms. That's when I might use the as needed reliever therapy. And so really, for the most part, that's going to be budesonide formoterol in inhaler form. And I'm going to have patients take, 2 puffs of that with symptoms whenever they have symptoms. That's one approach. Another approach, and I'm not sure that this is explicitly stated in the guidelines, but many of us do this, would be if patient knows that their group exercise class is going to trigger their symptoms, I'll say, hey, 15 minutes prior, go ahead and take that budesonide formoterol, 2 puffs before you exert yourself. And then you can take another couple puffs later if you do have symptoms, and just go at it that way. So long as the patient's keeping under 12 puffs, 10 to 12 puffs, 12 is the absolute max in a 24-hour period, there should not be any issue there. Because it's really limited by the formoterol dose, by the long-acting beta agonist.
Yeah. And maybe we should talk about, because this is, Cyrus, we've talked about this on the show. The GINA guidelines back in 2019 started to talk about this, and we talked about the Sigma trials, which I just have to, as an aside, if you have middle school children, everybody says like what the Sigma all the time, and there's all these like I don't know if Sigma's good or bad, but it's in this like lingo that these kids have. And I just thought it was funny when I was looking back that I didn't remember these were called the Sigma trials. So anyway, for what it's worth. So budesonide formoterol, why is that the reliever? Because I'm still seeing a ton of people on albuterol.
Yeah, and you'll probably continue to see that because it's like so ingrained in textbooks, and folks just learn that is the approach. And really, at this point, we have very good data to suggest that it really shouldn't be the approach. So the data for budesonide and formoterol in combination really goes back decades. That's the data that sort of demonstrated efficacy. But it really wasn't until recently, and that was Sigma 1, Sigma 2, and Novel Start. Those are 3 studies, which I'm sure we can link to in the show notes, but those are 3 studies that sort of solidified the utility of budesonide and formoterol in combination as being a quote-unquote superior option for asthmatics. Why is it superior? Because it provides reliable and kind of pretty impressive symptom control. There's a statistically significant reduction in exacerbations. And if you're using it, especially as kind of on an as needed basis, you're getting those benefits at a lower dose of corticosteroids. Now, some of the data is a bit conflicting in that if you have someone on maintenance therapy, they have better control than as needed, which kind of makes sense. We know that inhaled corticosteroid is a cornerstone of asthma therapy. If someone's taking it all the time, they're probably going to have less airway inflammation. But the downside is, of course, they're going to be on more inhaled steroid. And so your risks of like really thrush, and really that's the big one, is thrush, maybe other like cavities, et cetera, that might be higher. But then I think to get to the other element of that question is like, are all long-acting beta agonists created equal, or all short-acting beta agonists created equal? Well, the answer is definitively no. So formoterol is special in the sense that you get short-acting benefits of the short-acting benefits of, let's say, an albuterol with the long-acting benefits of a LABA. So it's really got kind of a dual mechanism. You get onset of relief within typically 5 to 10 minutes, and then it's going to last up to 12 hours. It really kind of depends on what's going on with the patient, what their trigger situation is, et cetera. But that's why we really like it. That's why it works in the way that is suggested by GINA, i.e. the SMART, or single maintenance and reliever therapy approach to asthma management.
Yeah, love it. And it comes up all the time on boards questions and, mix-app and what have you. But I still find when I'm talking to trainees that a lot of them have not yet been taught this when they're coming through medical school. Paul, I don't know if that's Paul Williams, I don't know if that's your experience as well.
It does not seem largely changed. The practice does not seem changed from 10 years ago, to be honest with you. It feels like it just has not caught up with the current guidelines. And there's a lot of inertia I'm seeing as well, where someone is on the SABA and you're like, well, probably we should actually update this to a more evidence-based inhaler. And people are like, I'll talk to them about that next time. So there just seems like a general lack of enthusiasm that I can't really explain, but it's what you're fighting against, Dr. Askin.
Well, and the thing is, like, it may be more convenient, it may be faster to not bring it up, but you're really doing a patient a disservice. So we know that patients have more exacerbations and more severe exacerbations when they're on SABA monotherapy.
Yep.
That's not cool. And we also know that tachyphylaxis is a significant issue. Also similarly uncool. So you give a patient a medication that makes them feel better. What are they going to do? They're going to use it more and more. But the sad thing of it is, we see this on the inpatient side a lot of the times when we're using, short-acting bronchodilators for asthma exacerbations. The law of diminishing returns, it's like, it's really bad with like donuts, and then it's like almost as bad with beta agonists. So it's very real, right? And so that's why I think that the GINA guidelines, in their infinite wisdom, and I mean that in a true way, like those guidelines make a lot of sense, and that's really what we should be following. I don't, unless you are in a truly resource limited environment, and I think that's got to be a place where you're like reliant on peak expiratory flows to make the diagnosis, or you're just kind of assuming people have asthma. Okay, maybe there's a place for it. If you are using albuterol in addition to another inhaled corticosteroid other than, let's say, budesonide, maybe you're using fluticasone, and then as needed albuterol on top of that, okay, that may be okay. Or you're doing sort of a similar approach where you're using maybe fluticasone and albuterol in the same way that you might use budesonide formoterol. So sort of this like a few times a day as needed sort of approach. Okay, fine. There's a place for albuterol. But I mean, to be fair, sometimes it is like you're prying away a security blanket from a patient. It's like, you don't need this anymore. You don't need this anymore. But I just take the time to explain this is why, and
right
there you have it.
Yeah, I think the other tricky part about this is the cost, because budesonide formoterol is not always affordable to patients. So
yes,
I'm still seeing a lot of patients on fluticasone salmeterol, which, and salmeterol it takes 2 hours or so, the onset, from what I recall. So it's definitely not 5 minutes. Like, and so they take that one, they feel nothing for 2 hours, and they take their albuterol, they feel something right away. So it just reinforces that, that's why they like that one. And that's why it's almost like if you can get them on formoterol from the start, that seems to be the better way to go.
Very true. It's dangerous too, right? Because for exactly that reason you described, is they'll be on the appropriate controller or an appropriate controller if that's your strategy. They don't feel anything from it. They feel something from the albuterol and like, I don't really need this one. I'll just, this is the moneymaker right here. This is the one I need because it makes me feel better. And so I think that just gets back to taking time to explain the method behind the madness and why we do it the way we do it. And then good follow-up and all that.
Paul Williams, I'm going to make, here's my analogy. It's like when someone starts taking Ativan for anxiety and then you try to put them on an SSRI.
Yeah, good luck.
You're like, I promise this is going to help control your symptoms in the long term. They're like, that one makes me feel something. That one I didn't, maybe they felt nausea or some like bad side effect, but they,
No, I think that's a great analogy.
It's tough. Okay. Wirtz, what's next? How are we doing here on this?
Where are we?
I know we have a lot to get to, but I feel like we're covering some ground. What's next?
No, I think this has been great. Can you talk a little bit about the Mandela trial and how we think about ICS albuterol? And then also just like when do you start with the MART therapy versus just the reliever alone?
Okay, great. So I'll start with the second question, if I may. So, and then I'll talk about Mandela. So when do I start maintenance and reliever therapy? There's kind of two cases, I think. I'll say that. So in someone who perhaps underreports their symptoms and says, oh, they're just with exercise, and I sort of start them on as needed, trigger targeted therapy, and then I find out that they're maybe not as well controlled as I had hoped, then I might transition that person to MART or SMART therapy, depending on if you are a fan of 5 or 4 letters, I guess. But yeah, and so the way that looks for me is, and this might be helpful to the listeners, is I say, okay, you're going to take 2 puffs in the morning, 2 puffs in the evening, and then you have another kind of 6 to 8 puffs to use over the course of the day to sort of manage symptoms as they come up. If someone's using 10 to 12 puffs a day every day, that's worrisome to me, and that would indicate there's something going on. But the flip side of that coin is, okay, how are they taking it? Are they just like grabbing the inhaler, shoving it in their mouth and kind of puff, and that's that? Or are they doing it deliberately? What does deliberate look like? Well, for me, I give patients a spacer, and I'm a reasonable person too. So I'll usually give the person 2 inhalers one that they can at least carry in their pocket, recognizing that they may not have room for a spacer, so they may just use that one as needed without it. But the maintenance doses, I want them to really take that with a spacer. And the idea there is it's going to force the patient to take a slow, deep inhalation. It's going to allow medication to collect in the collecting chamber and then be distributed to the lungs rather than to the back of the throat. That's another thing I see a lot of is like they coat the back of their throat. They don't get it actually into the airways. And they're like, why isn't it working? And why do I have thrush? Well, boom, boom. And then there's like the brushing teeth, swish and spit after use, all of that. So I go through all of that, upright, big breath, all that good stuff. And so, yeah, so that's kind of how I educate patients and how I go from as needed to MART or SMART therapy.
And we're talking about the same agent, budesonide for Formoterol. It's
Correct.
just, instead of just the as needed reliever therapy, they're doing the maintenance dose, like you said. And can you talk about the steroid dose with that, like the 2 puffs versus 1 puff? Because, I guess it depends on because there's usually a couple different strengths of inhaler.
Yeah. So if memory serves, it's like 80 and 160 are the common doses that at least I've seen. And so depending on how symptomatic I think the patient is, that might indicate whether I start them on the higher dose or the lower dose. If you're a purist and you're following GINA guidelines, you're going to start at the low dose and give yourself room to work up. But the reality is, especially recognize that things are a little biased from my standpoint, because oftentimes the patient has been seen already and then they're coming to me and maybe their symptoms have brewed in the background, things have gotten worse. So I'm a little bit more inclined, I think, than my colleagues in general internal medicine, family medicine, whatever, to start someone at a higher treatment dose and then step them down. Because I want to like get them kind of on the straight and narrow and then I'll move them back. But that's generally how I look at it and how I'll dose it. And again, that 10 to 12 puffs, that's really limited by the LABA elements, because we know that high doses of LABA can have cardiac side effects. That's why we don't do like LABA monotherapy. That's like a no-no. We really do it in concert with inhaled corticosteroids. So I guess I'll pause there. Does that kind of answer that first element of the question? Is there anything else that you wanted me to get to on that?
No, I think that's perfect.
Okay. So then the other question, so the Mandala trial. So really the Mandala trial is a pretty recent study. It really concluded that the combination of albuterol and budesonide used kind of as needed significantly reduced the risk of severe asthma exacerbations compared to albuterol alone in patients with moderate to severe asthma. And so that kind of dual therapy that was provided is kind of a more effective option for symptom relief while also reducing the need for systemic corticosteroids. But all that is to say, like, we kind of knew that. Like, we knew that budesonide and formoterol did that. And now we know that albuterol and budesonide do that as well. But I mean, we knew that even back in like 2004, 2001, that combination was a good one. But here we are talking about albuterol, which we've already discussed is like kind of an inferior drug to formoterol. And so I guess I don't really see an indication for that agent. Again, it's an industry-sponsored trial. A lot of these trials are industry-sponsored. So, that kind of, we could debate the merits of that all day long. But yeah, I don't really see an indication for it. And there are no head-to-head studies that I'm aware of. I actually searched this. There's no head-to-head study looking at like albuterol and budesonide and formoterol and budesonide, which one's better. And I don't even know if you'll ever see that, to be honest with you.
Yeah. And Cyrus, if I may, I mean, if the person won't give up their albuterol, you'd be like, all right, fine, I'm just going to give you albuterol, but you're going to sneak in the budesonide on them. Yeah. I don't know, Paul, that's like Paul Williams. Can you see that working maybe as like a
1,000,000%? Like, because I think the idea is to not be in there unprotected without the inflammation being reduced by the inhaled corticosteroid. So like however you get them there is, I'm kind of with Cyrus.
So that might, maybe that's going to help us, but it's probably expensive at this point. So
I think so. I mean, you're right. Jedi mind tricks to an extent is like, what are you going to do to get this person who's clinging to like their security blanket? Sure. Seems that's reasonable. I think like at my shop and a lot of other shops, you're not going to really have a choice. Like you're going to do one or the other based on what's available to you on your formulary or what insurance is going to pay for. I just think physiologically and pharmacologically, if I had my druthers, I don't really see a great place for that combination with albuterol.
And can I mention the step down? So let's say we did put her on MART therapy, the 2 puffs AM, 2 puffs PM, and then she was using 6 to 8 puffs as needed. And part of what I was reading, they were mentioning, and this was something from Journal Watch, they were mentioning that a lot of the efficacy of inhaled corticosteroids is achieved at low doses. So going up, you sort of have diminishing returns.
Yeah.
And they were saying that the high doses are associated with more side effects, and it might be as much as comparable as like taking 5 milligrams of prednisone a day if you do it over the long term.
Yeah.
So that you mentioned stepping down. Is that why we step down, because of that risk with steroids? And I even heard adrenal insufficiency is a risk.
Yeah. I mean, I think that systemic side effects from inhaled corticosteroid that I have picked up on in my practice, and recognize I'm relatively junior compared to my colleagues. So just in my own experience, I haven't seen much of that. I certainly see more of the local reactions. So again, thrush, cavities, etc. People just don't, maybe it doesn't agree with them or what have you. But I think you're absolutely right. The data would support exactly what you said. And so my thought is, well, every patient, I say this like on rounds all the time in the ICU and when I have folks in my clinic, every patient is at the end of the day an N of one. And so some patients are going to respond better than others to different doses. I think that there is a time and place to start the higher dose, but if I get the patient there, if I start the patient on a higher dose of inhaled corticosteroid and like, man, I'm loving life, everything's great, then really it is incumbent upon us to try them at a lower dose for those reasons that you described. The classic approach to step up, and this is kind of what's indicated in GINA, is to try a higher dose of the inhaled corticosteroid to see if you just haven't kind of hit what that patient needs. But again, you may see diminishing returns there, and that may kind of indicate you need to broaden your horizons and try something else, hit the problem from a different angle.
Paul Williams, what questions do you have about treatment here?
I feel like I'm in a fairly good place from the inhaler therapies. I did want to ask actually about montelukast. I just de-escalated. I feel like I've never started it, and I'm much more likely to actually take it off of medication list. But I would like to hear your approach as a pulmonologist and someone who deals with asthma much more than I do. When you use it, how you use it, and what you might who might be right for.
Yeah. So I think that there's sort of data for and against the use of montelukast. When I trained, it was commonly used as an adjunct. So typically, like your typical allergic asthmatic type patient might be on an antihistamine such as cetirizine. They might be on, back in the day, they might be on fluticasone salmeterol. That's what a lot of my patients were on. Now you're budesonide formoterol. And then you'd often see they're on montelukast too. So a leukotriene receptor antagonist. So there is some benefit, like I said. So it's beneficial in reducing symptoms and exacerbations in certain populations. And those populations are really allergic asthma, perhaps those with exercise-induced bronchoconstriction, and even those with aspirin-sensitive asthma, which is like another subset of asthma, which is probably outside the scope of this discussion. But there are groups where it is effective. It can be a helpful steroid-sparing agent, so it can kind of, because it's reducing exacerbations, can reduce the need for oral corticosteroids. And then it is an oral drug too, so it makes it kind of easier to take. And I did come across something that suggested it might have a benefit as monotherapy, which was crazy to me, in cough variant asthma. And if we get to phenotypes, maybe we'll talk about that. But generally, for like the folks that are listening here, I would say it's seen and used as an adjunct primarily in allergic type asthma. The physiology and pharmacology makes sense in that regard. Now, what is the data kind of against montelukast? Well, the big thing that's come up recently is this black box warning, and specifically it's neuropsychiatric side effects. So depression, anxiety, sleep disturbance, and really the most worrisome thing would be suicidal ideation. And so that's really where the black box warning came from. That being said, I did a little bit more digging, and there was a 2023 meta-analysis of 59 publications that really suggested that, sleep disturbances and anxiety are seen, but the other concerns, particularly the suicidal ideation, didn't really bear fruit, that concept, when they looked at these 59 studies in this meta-analysis. So all of that is to say, when I talk to patients about montelukast, I still bring it up, of course. I say, there is this potential, more likely to be, it's most likely that you're going to have no issues. It's possible that you could have some issues with anxiety or sleep disturbance, and there is a slight risk that you could have suicidal ideation. And I talk about that, and I say, okay, have you had behavioral health concerns in the past? And I really have a very open and honest discussion. And so I would say that with montelukast, the question is always, is the juice worth the squeeze? I think if someone has allergic type asthma and they're kind of already on, let's say, smart therapy, they're already on an agent like a cetirizine, you've perhaps already gone down the road of specific allergy testing, maybe allergy immunotherapy, then perhaps in that same breath, you might want to add something like a montelukast.
Okay, that's a great answer. Thank you. That's very clear. Yeah, we talked about that with Dr. Fadugba, Paul, right, on our
We did.
recent episode on rhinitis as well, and she said she was cautious about that.
Yeah.
And unless people have asthma, and allergy, she's usually not using it.
That's right. Yeah, there was not a role for allergic rhinitis exclusively, but with patients with asthma, then you might consider it.
And I've never used it like that either. So,
any other therapies or non-pharmacologic things that we should be thinking about for our patient here? Like, let's say we decided not to give her montelukast, but anything else that we would think about doing?
Yeah, there's a couple things that we want to consider, perhaps with this patient, but again, maybe with a more generic patient. The pregnancy element makes it a bit challenging in the sense that some things may not be feasible. We're often very sensitive to the fact that we're taking care of a patient and a second patient. And so I do think that makes us a little more concerned about the interventions, particularly pharmacological, and also recognizing that maybe some of these non-pharmacological interventions may not be feasible. That all being said, things that I would consider if they have more severe obesity, we definitely want to counsel and facilitate with respect to obesity, risks of obesity, and then weight loss. And in this day and age, in my mind, that may even be, having looking into a GLP-1 agent, if that's appropriate for that patient, even like surgical weight loss for sort of like a more extreme step. Obviously, you're going to start with your classic approaches to, calorie restriction, increase activity. But the reality is, and I don't want to go on the soapbox, we know that obesity is a lot more complicated than stop eating and go exercise. Like, it's a much, much more complicated disease than that. It's heavily stigmatized. And then when folks have shortness of breath, that even contributes more so, I think, to some of the biopsychosocial aspects of their obesity. So it's just really, to me, that's a very important thing. I spend a lot of time talking to my patients about that. And trying to help motivate them. And to me, none of the tools are off the table. So that's a big thing. We really have good data to suggest asthma control is more challenging in the setting of obesity. Exacerbations are more frequent in the setting of obesity. So I'll get off my soapbox and then move on. So as far as exercise goes, that's another big thing, not irrespective of this obesity discussion. But this is kind of an important one. So you'll hear a lot of folks say, "Oh, I've exercise-induced asthma," or "I have asthma because of my exercise." Well, that is like the worst thing. It just like kills me on the inside when I hear that. So if you look at the Quad AI guidelines, which is kind of the allergy immunology version of GINA, and if you talk to folks in the field that have been doing this a lot, I will often refer to exercise as a trigger and say you have asthma with an exertional trigger. But I'm very particular to not say, "Oh, you have exercise-induced asthma," so that they don't leave my office and like, "Oh, I just need to stop exercising, then my asthma will go away." Because we know that the reality is the reality is the reverse. Like, you want your patients to improve their musculoskeletal strength, their neuromuscular efficiency, their obviously cardiopulmonary function. All of those things are going to help their asthma control. We don't want them to stop exercising. So that's important.
So we convince them, we have to reinforce the fact that just because you have asthma doesn't mean you can't exercise. We should be able to get you to be able to exercise.
That's the goal. The goal is to facilitate exercise and normalcy. That's one of the sort of triggers that to me is non-negotiable. It's like, we have to find a way to get you to exercise. We may have to change what that looks like for you. It may not be like, sprinting intervals in the middle of a dust storm when it's hot and humid. Like, maybe we have to get you, on a bike indoors or something like that, different options. So that's kind of that other soapbox that I'll step off of. As I'm stepping off, I'll say, consider pulmonary rehab in these folks too. So if they need some encouragement, they need some support, pulmonary rehab is a good option. Last couple of things I'll mention. So trigger removal, if possible. And this can be helpful. Like, this could be a place where a subspecialist can help. because they can really maybe drill down what the triggers are. They can do maybe a more in-depth history. They could also explore the possibility of occupational type asthma and maybe work through that element. But definitely trigger removal whenever possible. I often will have my patients journal when they have symptoms, and then they bring it back to me and they're like, oh yeah, so I had symptoms in this scenario 7 times. Like, oh, well, maybe we should not do that. And then finally, and this is kind of pharmacologic, so I'm sorry, but I have to put this in. So vaccines. So flu and COVID for sure. RSV, now that it's available in the kind of the appropriate patient. Pneumonia in the appropriate patient. Those vaccines can really help because that's gonna help reduce other potential insults to a patient.
Yeah, and the pneumonia vaccines, even for patients under, they just lowered the age to 50, but even patients under 50 should get a pneumonia vaccine if they have asthma, right?
Yeah, Cyrus, you alluded to this earlier. I don't want to escape this case without kind of coming back to it and talking about it. It's a concept I was super unfamiliar with, this idea of sort of phenotypes in asthma and what you do with them. So you talked about like high T2 and type 2s, and I nodded wisely because that's what I do when I don't know what someone's talking about. So could you...
Me too.
Could you educate me, a dumb simple country doc, and sort of what those phenotypes are and sort of how they might actually impact your management?
Yeah. If I may, let me briefly scratch the surface on some of the more advanced concepts in therapy, because that's really going to dovetail with the phenotypes. So all of that is to say, once you've done your smart therapy and a patient needs more, that's really when things get confusing. And probably when I would recommend for most folks to refer to a pulmonologist if they haven't already, because of this idea of phenotyping. So again, to set the stage, there are a lot of options for therapy beyond your inhaled corticosteroid and long-acting beta agonist. Do you put this person on an antimuscarinic agent? Do you put them on omalizumab? Do you put them on one of these like a benralizumab, a dupilumab, et cetera, like all these amabs? It gets pretty confusing. So that's really where your phenotyping can play a role. So typically what we'll do, if it hasn't already been done, is we'll obtain kind of a panel of testing. So if for whatever reason you want to set up your patient for success, like go way above and beyond, before you send them to us, you might get a CBC with differential to look really for an eosinophil count, a C-reactive protein. You could get immunoglobulins, really specifically IgE, but you could check out a full panel. You could consider getting a fungal precipitans, although you could also leave that to us. That's really looking for allergic bronchopulmonary aspergillosis primarily, which can be a situation where asthma doesn't really respond the way you expect. It's because they have an underlying fungal infection. Imaging, so chest x-ray if it hasn't been done, high resolution CT scan, allergy testing, and then even things if you really want to go crazy like ANCA, BNP, echo, all of those things. So those are all things that can help us with our phenotyping. If you haven't ordered them, no sweat, I'll take care of it. So you get those things, you've got a patient that's like, not really responding well. That's when we get into the phenotypes. And so the phenotypes, essentially, you've got your classic allergic asthma. That's going to be your high T2 or your type 2. This is usually going to be your most easily recognizable. In a case like the one that we talked about earlier, you've got this family history, you've got some eczema going on, allergic rhinitis, maybe some food allergies. That's, again, your classic kind of high T2 or type 2 asthma. You might get an induced sputum that has elevated eosinophils on the sputum sample. That's something that we would do. Potentially. And just briefly, because I can't not talk about the physiology here. Essentially, you're just talking about high or pathologic elevation in T helper 2 cell count relative to the other cell lines, which results in increased production of IL-4, IL-5, and IL-13, which can sort of like add fuel to the cytokine fire, which coincidentally are the targets for the biologics that we would be using. And so that's why, again, getting that testing can be helpful. Moving on, you've got your kind of low T2 asthma. So these are folks, when you do all your testing, you might send them for allergy testing, et cetera. Nothing really comes back positive, but they have bona fide asthma. The thing to know there is those folks are often harder to treat. Their response to inhaled corticosteroids is often not as impressive as you'd want it to be. And really, these are the folks for whom a lot of the biologics are not a good option. There's kind of the new one that came out recently. It's like Tecamilumab or something. I can't remember. I remember the brand name, but But there's the new one that came out, which is really for like low or high T2. It's basically works on a different part of the, it works like upstream of those agents, if memory serves. So that would really be the option for those folks, and why again, phenotyping is helpful.
Is it tezepelumab?
Yes, tezepelumab. Yes. Sorry, that's the only one I remember.
Obviously, Cyrus. This is embarrassing for.
I'm embarrassed.
We basically tied both arms behind your back by saying we couldn't say brand names. So, so I appreciate
that one in
the
particular.
effort.
That one in particular, like it's a pretty memorable brand name. But yes. So as I remove my foot from my mouth, that one is really your option for those low T2 cases. Mm-hmm. And then briefly, I'll talk about the others. So cough variant or cough persistent asthma. So these are folks who don't have necessarily shortness of breath, but they have cough as a principal symptom. Again, maybe montelukast could be more helpful in these folks, but typically we're treating them similarly. And then you've got this idea of adult onset asthma, which basically we kind of treat those folks like regular asthmatics based on other elements of their history. And then finally, you have this asthma with persistent airflow limitation. Is that asthma COPD overlap or ACOS? I don't know. It depends on the patient's history. Those are folks, if they skew further towards the COPD side of the house, you might put them more readily on a long-acting muscarinic antagonist. And then finally, there's this asthma with obesity, which is considered its own phenotype, but really that gets back to what I was talking about earlier. So I think that does a pretty good job of talking about the phenotypes in the context of the biologics and the other therapeutic options. I hope that's helpful.
Yeah, that's great. I mean, maybe a standing ovation for that rapid recap. Paul Williams, any other questions about that? Is that...
No, that's very helpful. I just want to sound smart when I'm talking to my specialist, Cyrus. I feel like that at least gets me started.
But
I'll probably not be ordering the extensive panels. I will leave that to the pros.
Yeah,
for sure.
But I think the CBC with diff, the CRP, the IgE, I'll probably order that. The fungal testing.
That way lies madness, Watto. You're asking for trouble. It's going to come back abnormal, and then what are you doing?
I guess it depends, or I might reach out to the pulmonologist and ask if they have an appointment in a month or two. I might ask if they want me to do any of this testing ahead of time, depending on your relationship. But it can be more efficient for the person.
One thing I'll also just mention here is like, this was a lot of information to go through. And for folks that are caring for like the broad spectrum of the human condition, it's a lot to remember. The GINA guidelines are really great for this. It does spell that stuff out. And so actually, if you go to like page 144, it talks a lot about the biologics specifically. And like, so if your patient is on one, you can get some information on there. And then there's also a portion where they actually have it color coded. So it's like there's green and there's blue charts and text. Mm-hmm. One portion is for your sort of primary care. The other portion is for your specialist. And so if you're ever like lost or trying to figure out like where to draw the line, it's such a great resource.
Yeah. Okay. So I think we need to go on to the next case. Wirtz, can you read that for us?
Yeah, absolutely. So it seems like you've just been doing a terrible job, because a few months later, you see the same patient back in your clinic for a hospital follow-up visit after a recent hospitalization for an asthma exacerbation. This is her third exacerbation this year. Each episode typically resolves with steroids and nebulizer therapy. She normally takes a medium dose ICS formoterol inhaler, 2 puffs twice daily and as needed. She feels she never quite returned to her baseline since hospital discharge 2 weeks ago, and continues to have cough and shortness of breath with exertion. She's also been using her inhaler more frequently for rescue purposes, often 2 to 3 times per day. On physical exam, you notice she is breathing 23 times per minute and wheezing is noted. She looks mildly uncomfortable but not fatigued. So what factors are you paying attention to when deciding on sending this patient to the ED versus a outpatient approach?
So again, I will start this discussion with the caveat of the patient is pregnant. So like my threshold to send that person to the ED or bring them into the hospital is going to be extremely low, mostly out of, again, the just my overall concern. Like, I don't know where this patient is ultimately going to end up. And I think like obsing them for a day or two and treating them under my kind of watchful eye or someone else's watchful eye is maybe safer in a patient like this, or perhaps one that's a little bit sicker. 23 times a minute's a decent, respiratory rate. But if you're on the fence for this lady or for another patient, there are a couple of tools that you can use. So getting back to that discussion we had on peak expiratory flow. So this is really where that is helpful. I don't think I've ever used it for diagnosis, but that's because I don't work in a resource limited setting. However, if you obtain a PEF in a patient who you're diagnosing or whatever, and you know what their PEF is on the best day, so their peak expiratory flow, their PEF, you know what that is on their best day, you can then look and be like, oh, well, can you do it for me here in clinic and see what they do. Now, this is super nerdy, but there is up to like a 20% variability depending on the device that you use. So there is that consideration. But if the person's PEF is like great, and then today it's just in the toilet, that's probably not good. I think we can assume that that's probably real. So that's one thing. So like if it's 40-50% of what it should be, that's not great. If the patient has underlying comorbidities, structural lung disease, etc., that's going to move the needle for me towards like admit versus treat at home. A lot of times I'll talk to patients over the phone, so I won't actually have the benefit of seeing them. That's also going to make me more likely to bring the person in just because I can't see them. But even more so if they're like 4 or 5, word sentences, huffing and puffing on the phone, struggling to breathe. Like I had a call like this just a couple of weeks ago, and I was like, ma'am, you sound awful. Like do you want me to call you an ambulance right now? I'm going to call you an ambulance right now. And she's like, no, my colleague is right here. I promise. She's taking me right to the local ER. And I was like, I'm going to call you back in 5 minutes. If you're not on the way or at the ER, I'm going to call you an ambulance. And then so that was, those situations, they do arise. And that was pretty stressful, but yeah, if they sound terrible over the phone, I don't mess with that. Like they're going to get someone to lay eyes on them. If I'm wrong, cool. If I'm cavalier about it, then it's not cool because they could be an extremist, and that's not okay. And so, yeah, I mean, I think that's kind of how I look at it.
Cyrus, so you don't just give them antibiotics over the phone and tell them to call it a day?
Yeah, I actually, I send them to their nearest procedure clinic and get a PICC line, and I start them on like a carbapenem.
There you go.
To make
Beautiful.
Sure that I'm not missing anything. No, so that's a great point. So I was because there's a few different places we can take this. It's like asthma action plans, home treatment approach, etc. So I guess what I'll say is for a treatment approach, if I may talk about treating briefly, to your point, Matt, we really don't use antibiotics in exacerbations of asthma classically. If there is something else going on, if we think this person has a pneumonia, if they're like febrile with a mucopurulent cough and they had sick contacts, okay, sure. That's enough for me. But generally speaking, there isn't a lot of utility for antibiotics. Don't conflate that with azithromycin that we might use for asthma therapy as an adjunct, just like Montelukast. So we can use it as an immunomodulator in certain patients. There's actually pretty good data for that. This is more like acute exacerbation, put them on antibiotics, yes or no. They've got to have symptoms that are consistent with really like an infection, best I can tell.
Yeah, like it has nothing to do with the asthma. It has to do with what infection they have, whether or not you give an antibiotic. It's not like COPD where you count the cardinal symptoms, and if they have 2 or 3, then you treat. Okay.
Yes, I mean it's yeah. In I guess the way that I would approach it for listeners is in COPD, you should ask yourself, why am I not going to give this person antibiotics? And asthma, you should ask yourself, why should I give this person antibiotics? And I think if you approach it that way, really both disease processes, you'll probably end up at the right answer most of the time, which is the best we can do. And then otherwise, things I'll do for a patient at home is, increase their dose of their, smart therapy, perhaps, or tell them to take it more frequently. Potentially have them use their nebulizer if they have like nebulized budesonide and nebulized albuterol. For folks who are having a little bit of a harder time, perhaps more frail individuals, that can help sort of take the negative inspiratory force element out of the equation. So if you're really constricted, sometimes it can be hard to generate enough force to actually get the medicine in your lungs, whereas a nebulizer can be a more passive process. So that could be something you can do. And then of course there's the like 40 to 60 of pred that you can do for 5 days typically. Maybe a few more if you're thinking this person, for whatever reason, would benefit from 7 or 10. Although the standard is usually 5 days of 40 to 60 of oral prednisone for folks that you think are good enough to send home or good enough to keep at home with a phone follow-up in 24 to 48 hours.
Paul Williams, are you writing asthma action plans as America's PCP?
Not as often as I should, if I'm being honest, with myself and our listeners, but it's something I should get more in the habit of doing.
Yeah, so Cyrus, can you talk us through that?
I mean, I feel like a fraud because I'm kind of with Paul on this one. I don't use them as often as I probably should, but recognize that my patients have pretty good access to me. So like they just call me if something happens, and then I, can help them out. And And the other thing I'll say before we get to that is like just a plug for our colleagues in the ER. Like our colleagues in the ER are so good at treating asthma when those folks show up that I rarely see the inpatient asthma. So you've got this combination of like a really great security blanket to fall back on and patients that have good access. I probably don't use them as often as I should. That being said, for many of you guys that are working in the community, it's actually pretty helpful. So what is it? It's basically like, this is what to do if you're feeling short of breath and if your symptoms are starting to get the better of you. So the way it works is typically you'll see these charts, and I guess our colleagues in pediatrics are probably better about using these, but the charts are very similar. There's like a green, a yellow, and a red. So like, a stoplight or whatever. The green is typically going to be if you're at 100 to 80% of your best or your predicted PEF. 80 to 50% would put you in the yellow category, or caution, if you will. And then less than 50% puts you in the red or kind of warning category. So the way that I typically would approach this, if someone's calling me on the phone and they're sort of in that yellow zone. So if they're in the green zone, it's like, okay, well, this is that variability that you might see in someone from day to day. There's nothing to really do about that necessarily. Or really by definition, there's not a lot to do with that. If someone's in that yellow zone, it's like, okay, well, I'm going to talk to them. I'm going to ask them questions. I'm going to assess them, make sure they're actually in the yellow zone. And then I might have them take more of that budesonide formoterol. I might have them switch to nebulized therapies. And again, the key is like, do, act, follow up. Or sorry, I should say assess, act, follow up. So what do you think they need? Have them do whatever it is you think is appropriate, and then follow up in 24 to 48 hours. That may be systemic steroids. It kind of depends on what I'm hearing from them. Also, I may just have that person come to the clinic in a day or two. So I'm not as concerned, like this person needs something stat. But that's usually my approach. And a lot of times this will be written out. The idea of the action plan is like, they're not calling me for guidance. They're calling me to say, hey, I felt bad. I checked my PEF. My PEF is like 60% of my best. A couple weeks ago, I was at 100%. And so I started doing A, B, and C. If this is someone who I've known for a while, I might give them prednisone to have at home. And they might be like, yeah, and I started taking my prednisone too. So that really it empowers the patient. It provides some element of self-efficacy. It also frankly makes your life a little easier because you already have a plan to fall back on. So that's usually how that works. And then if they're in the red zone, i.e. they're less than 50%, you could have them mess around with home therapies. And you're probably, what I would probably do practically speaking is I would do everything I would do for the yellow zone. I would necessarily, oh, hello, kitty. I would definitely start the patient on their steroid or tell them to start it. And I would tell them to come to the ER and be evaluated in the ER. That's typically what I'm doing. Because again, if that patient if I'm overcalling it, that's fine. If I'm undercalling it and they come in with hypoxemic respiratory failure, I lose a lot of doctor points. And more importantly, they may not be doing so hot, and that's not cool either.
Yeah, you anticipated a question I had, which I had, and it makes for a neat catchphrase. I'm not sure how entirely true it is, but someone who once told me that if a patient with asthma presents the ER for an exacerbation, that's a failure of outpatient care, and actually talked about this idea of having courses of antibiotics, not antibiotics, forgive me, steroids to take it home for sort of these moderate exacerbations. So I was going to ask what your practice is around that, but you answered that perfectly. Thank you.
I was going to say to the audience, Cyrus said hello kitty because Paul's cat jumped on the back of Paul's chair,
Yes,
which happens every time we record.
No, that's just a weird verbal tick Cyrus has. He just says hello kitty from time to time.
Yeah, it's
and
we usually
now
fix it in post.
I think I just saw your cat jump into the litter robot, Paul.
You did not.
When you go, you gotta go. You gotta go. Yeah, I get that.
Okay.
So.
All right. Well,
Yeah.
have we done it, guys? Are we at the end of this thing? Do we have more to go through? I think we talked about our asthma action plan. We talked about when we might that most people with asthma are not going to need antibiotics unless they have a separate infectious thing going on. Talked about giving 40 to 60 of prednisone, usually for 5 days. Anything else that we're going to be doing for an exacerbation?
I mean, there's a ton that we could talk about at another time, for more inpatient focused stuff. If you do get to that point, I think that's outside of the scope of this discussion. So I think we're probably pretty good.
Yeah. Wirtz, what do you think? Anything else that we're missing here?
I think this has been fantastic.
All right. So let's go to some take home points, Cyrus. Knowing we're leaving some stuff on the table, maybe an inpatient episode, or an asthma COPD overlap or something in the future. But, we have plenty of time to have you back.
We do. Not going anywhere.
What are some take-home points you want people to remember?
Yeah. So I think first and foremost is, many diagnoses are clinical diagnoses. Asthma really shouldn't be a clinical diagnosis, in most cases, like solely a clinical diagnosis. So yes, you should suspect asthma if a person's presentation is consistent with asthma, but really it's a diagnosis that should be supported by spirometric values. And if spirometry is not consistent with asthma, and you've also done perhaps a provocative test like a methylcholine challenge test, and you're still not getting the results that you would think are consistent with asthma, I think that it's incumbent upon the clinician to start looking at other diagnoses before empiric therapy for asthma. You'll miss things like inducible laryngeal obstruction or vocal cord dysfunction. You'll miss cardiac disease. You'll miss perhaps other structural lung diseases by treating empirically for asthma. So I think that's probably, if people take anything away from this, it's that do not fall back on this person has shortness of breath, let's give them an albuterol inhaler. No, there's a lot more to it than that. It's a lot more nuanced. I think that dovetails nicely with the idea of only under rare circumstances should you be really writing for an albuterol inhaler in 2024. I think there is a time and place for it, but that time and place is kind of like warfarin. The indications are fewer and further between. I would say similarly, that's true for albuterol monotherapy. So that's probably one other take home point. And then I think, really the other two big ones would be, for exacerbations, have a pretty low threshold to lay eyes on that patient or have that patient seen, because really folks shouldn't be exacerbating a lot once they're at steady state. That's going to help make sure the patient is safe, but also make sure you're not missing an alternative diagnosis. Who's to say that your, 63-year-old with asthma didn't just manifest their first episode of acute decompensated heart failure? You may not be able to tell that over the phone. And then finally, I would say, I like to think we're pretty friendly in the world of pulmonary medicine. So please, let us help. I will be fully transparent and say, at least in my station in life, it can be a bit frustrating when I read the consult and it's like dyspnea is the assessment or problem. Plan is referred to pulmonary, and literally nothing has been done. But I think if you've tried to do something for that patient and maybe gotten some baseline spirometry and checked a lab or something along those lines, and you're kind of stumped, then by all means, please let us help. Part of that too is it's hard for us to help if we're seeing a patient with absolutely nothing in the background that's been done. And we want to try to help people efficiently. Your patient's time is very valuable. A lot of times they're waiting for the appointment. They're waiting to see me or whomever. And so I think being mindful of all that is helpful. But I guess those are my kind of 4 big take home points.
There's no way that's a Paul Williams consult coming to you. That patient's going to be wrapped up nicely.
Nothing done. The progress note's going to be sparse. It's going to be maybe something about athlete's foot or something, and that'll show up on your doorstep. And Godspeed and good luck.
I did the open lung biopsy in my clinic, and the darndest thing, I still couldn't figure out what's going on. So, yeah.
All right. Well, thank you so much, Cyrus. We will fade into the outro. All right. And actually, no, before we fade into the outro, check out Critical Care Time. What are you waiting for? Subscribe, give it a 5-star review, anything. Cyrus, where can they find that?
Thanks. Yeah, no, I appreciate it, Matt. So, like I said, Critical Care Time wouldn't exist if not for the Curbsiders, and I mean that wholeheartedly. And so I appreciate the opportunity to represent us and also to join the team again for this. So we're on Instagram, we're on X. Our website is www.criticalcaretime.com. We're really the podcast for everyone who cares for the critically ill. So it's really not just for intensivists. In fact, we're really focused more on early career physicians, nursing staff, respiratory therapists, et cetera, all of those folks that really make critical care possible. We've had our really shockingly, in my opinion, successful first couple of years. We're really excited about it. Myself and my co-host, Nick Mark, are loving every second of it. And so, please check us out on your favorite podcast app or on YouTube. Whatever works for you works for us.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. Time to shine, Paul Words.
Yummy.
No pressure.
He didn't want to say it.
Yep. No, just forced him into it, and the look of shame on his face is really worth the whole effort. Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com. And sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value practice-changing knowledge, so we want your feedback. Email us at askcurbsiders@gmail.com. Please subscribe, rate, and review the show wherever you listen, YouTube, Spotify, Apple Podcasts. A reminder that this and most episodes are available for CME for all health professionals through VCU Health at curbsiders.vcuhealth.org. A special thanks to our writer and producer for this episode, Dr. Paul Wirtz, and to our whole Curbsiders team. Our technical production is done by Podpaste. Elizabeth Proto runs our social media. Jen Watto runs our Patreon. Krista Chu-Manchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, I have been Dr. Matthew Frank Watto.
I've been Dr. Paul Wirtz.
And as always, our main Dr. Paul Nelson Williams, thank you and goodbye.